We All right, so welcome to the first of the Certified Revenue Cycle Representative coaching courses. Just a few housekeeping things before we get started. Make sure that you are on mute. Make sure to turn off your cameras. At the end of the course, if you have any questions that we'll go over, you can turn back on your cameras and go off mute. If you have any questions while we're going through this, please just put them down into the chat and someone will answer them as we go through. If they're technical, they will be answered by someone through the chat. And if they are more about the content, we will go through them as we go through the course. We also want to remind you all that to sign in to the HFMA portal, and from there, you're going to have to do the online courses that correspond to each of these training sessions. Just doing the training sessions along with us is not going to prepare you for the test. There's a lot of content, a lot of things that you're going to need to know, and therefore we just don't have enough time to get through it all. So make sure you do those courses, and then we can answer any questions at the beginning of future courses that you have as you go through those. And again, if you have any questions, put them into the chat. So my name is Christine Ben, and I will be taking you through the first half of Unit 1. So I started my career off actually as a revenue cycle consultant, which I don't even know how that happens to people, but it happened to me. And from there, I was at PwC for about 10 years, working my way, doing all sorts of different revenue cycle projects, Epic implementations, patient access redesigns. And then I went from there to the Director of Patient Access at Johns Hopkins All Children's. And most recently, I am the Chief Operating Officer of C3 Revenue Cycle Solutions, where we focus on financial clearance outsourcing, process improvement projects, and utilization review and clinical and technical denials. All right, so moving on. Today, we're going to walk through half of Unit 1. So we will start with the patient-centric revenue cycle overview. And then we will end with the very exciting topic of compliance and HIPAA regulations. Again, I want to reiterate how important it is that you take the HFMA CRCR training courses that are on the website before our call next week. We will give some time at the beginning of each session for any additional questions, and then we're going to move on. You will not be able to pass the test by joining these sessions alone. There's a bunch of content we're unable to cover here. That's my disclaimer. All right, so the first thing that we are going to talk about is the patient-centric revenue cycle overview. So there are 3 critical segments of the revenue cycle, and this has been an evolution over the past decade. In my experience, revenue cycle has not always been focused on putting the patient first, and this shift has been driven by consumerism and demand. Throughout this course, you will be able to identify the activities that occur within each separate segment of the revenue cycle. So if we look at it as a whole, we have our 3 different main sections. So healthcare revenue cycle was not something I or anybody I know learned about in grade school or college, and it's hard to explain, especially to people who are outside of the industry. So for example, my mom thinks I'm a doctor. No matter how many times I tell her I'm not, she doesn't get it. And maybe she just wants me to be a doctor. I don't really know. But the way I explain it to people so that they can kind of understand what I do is everyone has been to a doctor's office. So you schedule your visit or procedure or whatever it is. You may or may not have an order or referral with you. You come in, you get registered, and they ask you for a copay or some other estimate of your patient responsibility. They bill your insurance, they bill you, and hopefully you don't get sent to collections. That is the revenue cycle on a small scale. It includes all of the major processing steps required to process a patient account from their request for service all the way through to zero balance. As we move from point to point, it's critical that the providers optimize these steps to avoid negative downstream effects. It's also important to note that the patient experience with revenue cycle processes can positively or negatively impact their perception of the physical care they received while they were at your organization. I mean, we've all had situations where our insurance is loaded incorrectly when we go to either the physician or a dentist or something like that. And you end up getting bills and you spend all this time trying to figure out how to get a hold of someone to get it fixed because you keep getting statements. These are things that can very negatively impact your organization. So we want to make sure that we can create a streamlined, positive experience for all of our patients moving forward. So this is the first part of the revenue cycle continuum. Most people know this commonly as patient access or pre-services. Scheduling and pre-access processing really set the stage for effective patient communication and data collection. As each step is completed, the information moves downstream. It is absolutely critical that providers optimize these steps to avoid downstream impacts, such as denials, an increased cost to collect, increased bad debt, and dissatisfied patients. During the scheduling and pre-registration components of this phase, the encounter record is generated and the patient and guarantor information is obtained and or updated as required. You're going to screen for medical necessity. You're going to look at coverage and make sure the service that's being provided is a covered benefit. You're going to get pre-authorization or pre-certification if it's necessary. You're going to create an estimate to inform the patient in advance of service their costs, which includes a deductible, coinsurance, and copayment amount. This should all be done prior to service to help the patient make informed decisions and get assistance like Medicaid enrollment or financial assistance programs when needed. If for some reason a service is not medically necessary, staff should then reach out to the referring provider and see if there are any additional diagnoses available to support the coverage, or present the patient with an ABN or notice of non-coverage. The healthcare consumer landscape is definitely changing. Therefore, understanding consumer attitudes and preferences across the healthcare journey is key for not only improving the experience, but also for supporting healthy behaviors, achieving better outcomes, and remaining competitive. A big topic of discussion that's at the forefront of all of our brains right now is surprise billing. Surprise billing patients with healthcare bills, like we did years ago, or not even that long ago, is not accepted. In addition, we do a disservice to our patients when we treat them clinically, but then financially bankrupt them with our surprise billing. The next piece we're going to move on to is, hang on, there's something in the chat. Pretty good. Time of service. So ideally, the scheduled patient has been pre-registered prior to them entering your organization, and they can go directly to their area to receive their care. Consents can be signed, and if it wasn't collected during pre-service, you can collect any kind of patient responsibility, and agreed upon payments are made. Positive identification is a key step here, and the patient is given an armband. Unscheduled patients or patients that weren't pre-registered will have to go through the comprehensive registration process at this time. Other components in this phase include the delivery of care, clinical documentation, making sure you document everything that has happened during that patient's visit, entering charges for all services that were provided or DME that was provided, case management and referral management. So the UR process, making sure the status of the clinical care that's being provided, the patient's in the correct status, and everything that happens while the patient is physically on site. And lastly, engaging the customer. So these are the processes that take place post-service, or as we typically call it, the back end. So post-service includes the account activities that occur after the patient is discharged until the account reaches a zero balance, such as final coding of all services, preparation and submission of claims, payment processing, balance billing, and resolution. This process is critically dependent on the actions that happen further upstream in the revenue cycle during pre-service and time of service. Providers should invest in optimizing processes and embracing technology to avoid rework and increase, which can increase the cost to collect on the back end. On the back end, patients want healthcare conversations and communication that are personable to them. They want you to know the answers when you call to ask. No longer can we treat each patient the same, both in collection conversations and modalities of conversations. Everybody wants more digital channels of communication. They want chat, they want to be able to pay online, and they don't want to have to physically pick up the phone a lot of times. They want a digital way to communicate and get answers that they need. So the key points of this section are the three components of the revenue cycle: the pre-service, time of service, and post-service. Pre-service is everything that happens prior to the patient coming, such as authorizations, benefit verification, and scheduling. Time of service includes registration, patient identification, documentation, and charging. And then post-service activity, which includes anything that happens after discharge. So dropping your claim, working your denials, posting your payments, and then balance billing as appropriate. And that brings us to our first polling question. We'll give you a few minutes to do that one. I think that's probably enough time. And most people got it correct. So yeah, post-service is the third and final major segment of the revenue cycle. This segment includes all of the account activities that occur after the patient is discharged until the account reaches zero balance. Good job. Okay, so moving on to section 1.2, which is healthcare dollars and cents. So now more than ever, people are asking about the price of healthcare. They are called on to make more decisions and pay more out-of-pocket costs than they ever have before. They are looking for the information they need to find and pay for quality care. Healthcare dollars and cents is an initiative that aims to answer these questions to help make sense of price and value in healthcare. Patient financial communications. So these voluntary practices address the area where best practices are most urgently needed, focusing on financial discussions. These can take place in advance of healthcare service, at the time of service, in the ED, and in other care settings. They provide definitive guidance about when and where patient financial discussions should take place and who should participate, and what the topic should be. First and foremost, it should respect the patient's privacy. Of course, in the ED, no discussions should occur before the patient is screened and stabilized based on EMTALA laws. The provider-patient conversation should consist of the following: compassion, communication, written follow-up, compliance framework, and HFMA's adopter program. So unless you've been living under a rock, pricing transparency is probably one of the biggest topics in healthcare revenue cycle right now. This is certainly a hot topic for providers all across the country right now due to CMS's mandate to provide all charges in a machine-readable format and 300 shoppable services. The need for transparent healthcare pricing has never been more important due to the need to help consumers make smart, educated decisions about the care they receive. In order to provide a patient with information that is meaningful to them, several factors must be included. 1, the type of hospital service based on CPT or MSD or G code. 2, total charges. 3, contracts or fee schedules per health plan. And 4, real-time patient eligibility of current out-of-pocket responsibility. Recognizing the industry's need for guidance concerning this topic, HFMA convened a task force to develop 2 documents. They have a pricing transparency report and a consumer guide to healthcare prices. Both documents can be found in the resources section of this course. So this is a mandate that has received a lot of scrutiny also from provider organizations, specifically managed care departments. Some providers have chosen to take the penalties and not comply because they believe that doing so will impact their ability to compete in the market. HFMA created the Medical Debt Task Force that builds off of HFMA's patient-friendly billing work. Best practice include: educate. Communication must be clear, concise, correct, and patient-friendly. Establish policies and make sure they are followed internally. You must be consistent. You must coordinate to avoid duplicative contacts. You must exercise good judgment. And then you must look at timing. Start the clock when the first statement is set. Report and track both to the credit bureaus if needed, and track all consumer complaints that you receive. So the key points here are about the 3 revenue cycle, HFMA revenue cycle initiatives. And then communication. It's all about communication, empathetic communication. Takes us to our next polling question. Which items are not best practice? It's probably enough time. All right, yes, so report to healthcare plans when a patient account is transferred. Good job. Takes us to our next polling question. And the results are process compliance with 62%. Okay, so that takes us to our next section, 1.3, which is patient experience and satisfaction. So at the end of this course, you should be able to speak to all 3 bullets. Patients expect value from their healthcare dollar, including greater transparency of quality and price information. Patient satisfaction also means that the patient understands the provider's payment expectations and the terms. Today's patients as consumers. So HCAHPS is the Hospital Consumer Assessment of Healthcare Providers and Systems initiative. The objective of this initiative is to provide a standardized method for evaluating patients' perspective on hospital care. For additional information, visit cms.gov and search for quality initiatives. Of the 27, only 1 question encompasses the entire patient experience, which is, would you recommend this hospital to your family and friends? So every person at an organization is responsible for patient satisfaction and communicating empathy to patients. So in revenue cycle, as with every other area, it is important to go the extra mile by creating patient-friendly processes aimed at improving the overall patient experience. You want to implement processes that are patient-centric and efficient. Educating the patient about insurance coverage, out-of-pocket expectations can alleviate concerns. It is important to communicate financial information clearly, concisely, and timely. Hard cost is the loss of future revenue. Great clinical care, as we discussed earlier, can be eroded based on poor front end and back end revenue cycle experiences. Has anyone ever had experience with lab billing? I know I'm personally still fighting a lab who said I was in network and I wasn't in network and over a bill, and I keep getting, and actually I think at this point I paid it, but I still keep getting statements and things like that. And I don't even remember what my actual clinical experience was. So making sure that you have concrete processes and concrete communication with your staff or with your patients when they come in is very important. To improve quality and decrease back-end billing issues, insurance verification, pre-cert, and pre-auth should all be done prior to service. Over 40% of the information on a claim is gathered by access services. So the key points. Staff at all levels should receive extensive training in the art of welcoming behavior. They have a responsibility to efficiently and professionally gather all information necessary to support the patient intake process. It is important to recognize that there is a significant organization cost if policies pertaining to communication, customer service, and quality assurance processes are not established. And legal issues can also arise. So for example, you have a patient that comes in and they're registered with the wrong MPI, which stands for Master Patient Index. The correct patient arrives in the ED and is allergic to penicillin, and it is given to them. You can have some pretty serious legal issues on your hands. So it's important to make sure that you identify the patient accurately. Next polling question. Okay, let's see the results. So the goal of the HCAPS is to provide a standardized method for evaluating patient perspective on hospital care. So it's actually the first one. All right, moving on. All right, so now moving on to section 1.4, which is collaboration and continuum of care. So in this section, we're going to discuss departments and personnel with whom revenue cycle staff and leaders will work with in a patient-centric revenue cycle. So every different area of a healthcare system or organization is intertwined at some point. And it's important to make sure that the communication between all of the different departments flows efficiently. So healthcare providers today are faced with an increasingly complex operating environment. Using and optimizing technology provides a competitive edge and decreases costs by streamlining operations, increasing productivity, accessing profitability by health plan and patient type, and providing quality care. Organizations that do not keep up with information technology may be faced with limitations on their ability to attract and retain not only patients, but also staff. As a leader, it's very important to develop a strong relationship with your IT teams and advocate for support in these areas. Regulations are constantly changing. Workflows are constantly changing. Your teams are constantly being asked, can you do this? Can you do it this way? And you need to be able to be nimble with your systems so that you're not creating all these sub-processes or processes outside of your standard workflow. Having that relationship with IT or having the connection to the support there can allow you to make on-the-fly changes and quick changes so that you can continue to work with the change inside your standard process. Some common software applications that we use within our organizations are, we use scheduling software, ADT, pre-bill edits, electronic claim generation, payment tracking, exception-based work queues. At least I hope everybody's using exception-based work queues. AR management, task posting, denials, refunds, collection transfers, I know there's some EMRs that will state that they don't require any bolt-on technology. However, that's pretty incorrect because there are some additional bolt-ons that almost every single system uses. And some of these are electronic eligibility verification, estimation calculators, automated prior authorization, computer-assisted coding, your clearinghouse, your claim scrubbers, your automated claim statusing, denials and appeals support, and also some analytics. As patients become more comfortable with the internet, they are demanding online access. They expect providers to offer online scheduling, bill payment, customer chat, to name a few. It's also important that you collaborate with your clinicians and your clinical leaders. Although they are focused on clinical needs, as they should be, a number of their activities support revenue cycle as well. Some of the examples include reviewing the patient chart and armband to ensure accuracy, obtaining consent, especially where surgery is involved or minors are involved, entering charges accurately and timely, documenting care. And then it's also important to collaborate with your financial teams, so your finance departments. They are usually responsible for compliance with state and federal reimbursement reporting requirements. They also provide modeling for contract negotiations and estimate the impact of regulatory changes on the provider financial performance. All right, so our next polling question. Which is not a department that supports and collaborates with revenue cycle? I think you guys got this one. All right, let's see what we got. Woohoo, 100% assisted living. Good job, guys. All right. All right, so the continuum of care. This is a way of coordinating and linking healthcare resources, facilitating a seamless movement among care settings. It seeks to implement linkages to connect patients who are leaving the acute care setting with post-acute facilities and services. The coordination of care has gained importance as alternative payment models expand to include bundled payments. Physician offices provide the order, schedule the service, and obtain authorization, unless sometimes there's arrangements where the hospital does it. So the key point here is the continuum of care is a way to coordinate care that avoids duplicate efforts and waste. And it involves professionals in multiple different organizations and multiple different levels. So which option is not a continuum of care provider? All right, let's see. Health plan contracting, correct, 95%. Okay, so now we are moving on to the most exciting topic of them all, compliance and HIPAA regulations. Also one of the most misspelled acronyms in healthcare. So we will talk about a rise in corporate compliance programs, including their complexity and importance, components of the programs, the role of the compliance officer, HIPAA, including electronic transaction code sets, privacy, and security components. They cover the risk areas that are perceived to lead to potential fraud and abuse. Such risk areas include upcoding of MSDRG assignments, inaccurate or incorrect coding, bundling and unbundling of services, duplicate billing, billing for medically unnecessary services, waiving of deductibles and co-payments to entice business, and insufficient documentation. Believing that organizations are ultimately in the best position to self-police, the Office of the Inspector General, also known as the OIG, developed the Model Compliance Plan for labs in 1997 and for hospitals in 1998, followed by a dozen other guidance documents for pretty much every type of healthcare provider and service provider, like DME and also pharmacy. They cover the risk areas that are perceived to lead to potential fraud and abuse, which I've already gone through. So there are 16 essential elements to the program. There's self-reporting. There's a culture that encourages reporting. There's having a compliance officer. There's oversight. There's written procedures, including an employee code of ethics, training, an anonymous hotline, exercise due diligence with sanctioned individuals, monitoring systems, establish standards and procedure. Everything must be in writing. The plan must be effective, discretionary authority, independent evaluations, disciplinary actions, and you have to have an audit plan. So of those essential elements, if you don't follow the plan, in 2017, the Federal Justice Department recovered $2.6 billion for allegedly providing unnecessary or inadequate care, paid kickbacks to healthcare providers to induce the use of certain goods and services, and overcharge for goods and services paid for by Medicare, Medicaid, and other federal healthcare programs. All right. So which of the following are not essential elements of a compliance program? There's kind of a lot to read there, so I'll give you a second. All right, let's see what we got. All right, so the answers are 3 and 5. So automatic dismissal of any employee excluded from participation in the federal healthcare program, and the designation of a compliance officer. So you do have to have a compliance officer, but they probably should not be employed within the billing department. All right, moving on. Code of conduct. So the code of conduct is believed to be the backbone of the organization's compliance program. The code of conduct, if implemented effectively and enhanced as needed, can reduce weaknesses by helping employees and agents understand their roles and responsibilities, while fostering an environment where concerns and questions are raised without fear of retaliation or retribution. It is a living, breathing embodiment of the program. In the most effective programs, the Chief Compliance Officer reports directly to the Board of Directors trustees so that they can maintain independence. Office of the Inspector General. The OIG was created to protect the integrity of HHS. They identify and hold accountable those who do not meet program requirements. They publish an annual statement of work, but it is now updated as needed on a monthly basis. Some examples of the work plan include initiatives related to prescription opioid drug abuse, Medicare payments made outside of hospice, denials and appeals in Medicare Part D. Some well-known names that were issued corporate integrity agreements included Tenet, National Health Laboratories, and the University of Pennsylvania. HIPAA, HIPAA. So the goals of HIPAA broadly are the protection of patient information. They place restrictions of access to PHI, and they ensure that BAAs are in place for any of your partner firms. transaction sets. So there are 8 standardized code sets that are to be used for transmitting data back and forth between providers and payers. There is the ANSI set that most people are familiar with. So we have our healthcare claim transactions, which is your 837, your enrollment and disenrollment, your 834, eligibility and benefits, 270, 271, your payment and remittance advice, 835, premium payments, 820, status requests, 276, 277, certification and authorization, 277, 278, and your claim, which is your 837. So the final rule adopted standards for these 8 electronic transactions and code sets that are used throughout the healthcare industry. There's also a standard unique employer identifier, which I know all of you are familiar with, called the EIN. So on May 31st, 2002, HHS released its final rule, Health Insurance Reform, Standard Unique Employer Identifier. The use of a unique employer identifier is required under HIPAA. The rule adopts the employer identification number assigned by the IRS to be used in standard transactions to identify the employer of an individual described in a transaction, such as the transmission of enrollment or disenrollment information to a health plan. Any business required to furnish a taxpayer identification number, meaning that wages are paid to one or more employees, must use an employee ID number, EIN, as its taxpayer identifying number. The compliance date for the implementation for most covered entities was July 30th, 2004, and August 1st, 2005 for small health plans. Another number that we use quite frequently is the National Provider Identifier, your NPI. This is a HIPAA administration simplification standard. The NPI is a unique identification number for covered healthcare providers. Covered healthcare providers and all health plans and healthcare clearinghouses will use the NPIs in the administrative and financial transactions adopted under HIPAA. The NPI is a 10-position, intelligence-free numeric identifier, so a 10-digit number. This means that the numbers do not carry other information about the healthcare providers, such as the state in which they live or their medical specialty. Beginning May 23rd, 2007, the NPI must be used in lieu of legacy provider identifiers in the HIPAA standard transactions. As a healthcare provider, you must provide training to all staff within your organization on its policies and procedures governing HIPAA compliance. You must define protected health information and access thereto by individuals, payers, and business associates. You must ensure that training is based on the job responsibilities of staff who handle protected health information. The only exception to training staff is if an organization is a group health plan that provides only benefits and does not create or receive protected health information other than in the form of enrollment or disenrollment information. They are exempt from having to provide training to their staff. They are responsible for ensuring that a privacy officer is hired or designated, and ensuring that a contact person is hired designated to handle questions or concerns regarding to the protection of personal health information. Security of health information. So the administrative simplification provisions of HIPAA Title II require the Department of Health and Human Services to establish national standards for the security of electronic healthcare information. The final rule adopting HIPAA standards for security was published in the Federal Register on February 20th, 2003. This final rule specifies a series of administrative, technical, and physical security procedures for covered entities to use to ensure the confidentiality of electronic protected health information. The standards are delineated into either required or addressable implementation specifications. So key points in this section. So each healthcare organization has to have a compliance program. Within the revenue cycle, staff need to understand the importance of compliance with federal and state program requirements. Medicare program issues related to the 3-day window, the 1-day window, the Medicare secondary payer, and advanced beneficiary notices, as well as CCI rules, are keys to compliant claims processing. HIPAA requirements for privacy and security, as well as opportunities presented through the electronic transaction sets, also impact revenue cycle operations. And this actually brings us to our last polling question. So identify which option is not a work plan task mentioned in this course.
Christine, it's giving me an error, so let me try to keep sending it.
Okay. Well, the answer is A, reconciliation of outlier payments. And that actually brings us to the end of the formal presentation. If we want to open it up for questions or comments, somebody can do that.
Can you hear me, Christine?
I can hear you.
This is Christina. We do not have any questions in the chat at the moment.
Okay. Anybody want to call out a question? All right, well, just a couple reminders then. Make sure you go on to HFMA and attend the courses that correspond to these sessions. And in order to pass the test, you will need to do that because we can't cover everything. But thank you for giving us the opportunity to spend the hour with you.
Thank you. Great information.